In this video, we're going to talk about the anatomy of the extraocular muscles. Then we'll discuss the different types of scleral passes. We'll discuss the instruments used for scleral passes in strabismus surgery, how to properly load a needle to perform a scleral pass, how to fixate the eye, and lastly, we'll demonstrate how to perform a scleral pass on a model eye and in real-life surgery. The four rectus muscles form the spiral of Talot. The medial rectus inserts 5.5 millimeters from the limbus. The inferior rectus muscle inserts 6.5 millimeters from the limbus. The lateral rectus muscle inserts 6.9 millimeters from the limbus, and the superior rectus muscle inserts 7.7 millimeters from the limbus. This forms a spiral called the spiral of Talot, with the medial rectus muscle being closest to the limbus and the superior rectus muscle being furthest from the limbus. The thinnest part of the human sclera is immediately posterior to the extraocular muscle insertion. In fact, this sclera is so thin that it is about 0.4 to 0.45 millimeters. This is about the thickness of a piece of paper. And so we must perform scleral passes very carefully, because if you go too deep, you're at risk of perforating the globe. So I'd now like to talk about the two different types of scleral passes. There are advantages and disadvantages to both types of scleral passes. So when you're recessing or weakening an extraocular muscle, we'll again draw, here is our cornea, here is our extraocular muscle. There are two options. So you can detach the muscle from the insertion, and you can either suture the muscle further back on the limbus. So for example, if we're doing a 5 millimeter recession, you can directly insert the muscle onto the sclera. This is called direct scleral fixation. The advantage to direct scleral fixation is that we know that the muscle is in place and that there isn't risk of it slipping or moving. The disadvantage is that this muscle can no longer be moved or adjusted. So if you're planning to do adjustable sutures, direct scleral fixation is not the way to go. The other concern with direct scleral fixation is that this is the thinnest part of the sclera. As we discussed, the sclera in this location is about 0.4 millimeters from the limbus. The second type of scleral pass is a hangback suture. With a hangback suture, rather than directly suturing the muscle to the sclera, we pass the muscle sutures through the original muscle stump insertion, and we tie the suture ends in this location, allowing the muscle to hang back. Here is our hang back suture. The advantage to the hang back suture is that this muscle can later be adjusted using adjustable suture surgery techniques. This means that we can move the muscle forward or back following the surgery to fine-tune the alignment. The other advantage of a hangback suture is that you're not suturing through the thinnest part of the sclera. You're suturing through a muscle stump, which is relatively thicker. So technically, there's a little bit more ease. However, there are disadvantages to a hangback suture. Hangback suture does have a risk of the muscle slipping or moving, and some individuals feel that it is less secure. So next, we're going to demonstrate how to perform a scleral pass on a model eye and also in a real surgery. The instruments that you'll need for this module are a curved Castroviejo needle holder, a toothed forceps, and Westcott scissors. For strabismus surgery, we use a 6-0 vicryl suture with an S29 needle. For our model sclera, we're going to be using a silicone sphere, although you can use an orange peel or a banana. Another option is to use the foam that comes in the pack of 6-0 vicryl. When you load the needle, you load 2/3 to 1/2 of the way from the tip. The curve of the needle should curve away from the tip. I will now demonstrate how to do a scleral pass on the silicone model eye. You can use your hands to steady the silicone eye. You place the suture needle on top of the sclera, tracing the path that you want to take. You can then back up the needle and then with a slow, controlled turn of the wrist, pass the needle through the sclera. It is very important to keep the tip up at all times and to be able to see the needle passing through the sclera at all times. I'll now demonstrate that again with the second scleral pass. So again, we'll now load our needle 1/2 to 2/3 of the way back from the tip. Steady your silicone sphere. Place the needle on the globe, back up, keeping your tip up at all times, and slow, steady, and controlled. Pass the needle through the sclera, making sure that the needle is visible at all times. When you grab your needle, take care not to grab the tip of the needle, as this can dull the needle for future scleral passes. The foam insert that comes with the 6-0 vicryl suture makes a perfect model sclera. I'll demonstrate the technique here once more. Place your needle directly on the sclera, tracing the path that you're going to take with your scleral pass. Back the needle up and then slowly turn your wrist, making sure that the tip of your needle is up at all times. You can see the needle through the sclera at all times as well. Dr. Pavlina Kemp will now demonstrate how to perform a scleral pass during surgery.
At this point, we're going to make scleral tunnels, taking care to go partial thickness and not go posterior to the muscle insertion, as this is where the sclera is the thinnest. Same thing here through the other side. Making sure that we haven't gone through our original suture, we pull back on the first one. And now we pull the muscle up to the original insertion by moving the eye to the muscle so as not to stress the scleral tunnels. We place forceps the intended distance that we planned on recessing the muscle here, in this case 5 millimeters, and we can tie the knot right on top of our needle driver. Generally this is a 2-1-1 knot, making sure to have nice square knots which will hold. And we cut the tails with 1.5 to 2 millimeters on the suture. Needle driver is used to place the muscle where it wants to rest, recessed from the original insertion. The double hook of Manson is used to confirm where the muscle is sitting and that it is recessed how we want it to be. And an 8-0 suture is used to close the conjunctiva.